Is Dr. Joanne McManus, and Joanne has been a very important mentor of mine. So she's a consultant gynecologist and subspecialist in reproductive medicine in the Belfast Trust. But not only that, she is a BMS, or British Menopause Society accredited menopause specialist. And her interest from menopause and HRT dates back from when she was doing her MD, looking at the role of estrogen as an antioxidant as part of the cardioprotective effect. Her NHS roles are vast, includes not only fertility and assisted conception, but Joanne has pioneered and leads a large NHS menopause clinic. But she's also tertiary referral for all of adolescent gynae in Northern Ireland, and also is a gynae endocrine specialist as well. So hence why her interest in premature ovarian insufficiency. So thank you so much, Joanne, for being involved today, and go on ahead and share your slides. Thank you.
Okay, thank you, Emily. I think I'm sharing my screen, but I can't see my slides. So I can't actually see my slides, so I'm going to have to minimize my Teams window here. Sorry. And
we can see your slides, which is good.
Okay, so gone dark. Sorry. Oh my goodness. I can see nothing now, so I don't know what's happened. Sorry.
Take your time.
Right. Okay. I think that's. Oh.
Yeah, it's good for us. Yeah.
Oh, well, actually, it's not for me. So sorry, I can see nothing. Now I can. Now, what can you see? Just the.
Yeah,
you can't see the presenter view. Can you see the presenter view? No,
just it's unshared now, Joanne. So if you share again, and
all
then
right,
share your slides.
Thank you. Yeah, that should be okay now, hopefully. So I have.
So if you share and then share the window.
Yeah.
Perfect. If not, I can do it for you.
No, it should be okay. It should be okay. Sure.
Good. That looks good.
But you're not seeing the full slide, are you?
Not yet, but just about to, I think.
What's happened here? Sorry. Something's happened to my whole. Sorry about this. No, I can see it now. Can you? Is everything okay now from your end?
Yes, that looks great. Thank you.
Okay. Sorry about the technical hitches, and I did go on to do the test this morning. So, in this talk on premature ovarian insufficiency, I am going to refer to the recently updated ESHRA guidelines on POI, as well as bring in my own experience from looking after these girls and women in my fertility clinics, adolescent gynae clinics, menopause, and gynae endocrine clinics. So, the next slide, sorry, moving on here. What's the definition? Well, the definition of POI is the loss of ovarian activity under the age of 40, and that's different from an early menopause, which is defined as menopause between the age of 40 and 45. The incidence was previously thought to be about 1 in 100 or 0.1% for under the age of 40 and 1 in 1,000 for under the age of 30. But more recent studies have suggested that it's a wee bit higher than that, in and around about 3.5% for non-iatrogenic POI. It's important that it is considered as a medical condition and thereby differentiated from a normal menopause or even an early menopause. And I like to describe it to young girls as really you have a hormone deficiency. It's a bit like having an underactive thyroid gland, so when you would need thyroid replacement. So I say you've really got underactive ovaries, and therefore you need to replace the hormones that your ovaries should be producing at this stage in your life. And the recently updated guidelines in the management of POI were published at the end of November, I think, 2024. And they were a collaborative effort between ESHRA, ASRM, IMS, and the International Menopause Group. And they provide the best practice guidance for management of girls with POI. And they also include some very good patient resources with this, including this little fact sheet. Sorry, my slides are moving on back again. Including a fact sheet about 10 new things to know about POI and a link to the helpful app, the Ask Early Menopause app, which was published by the Monash Group. So to make a diagnosis of POI, there should be amenorrhea or oligomenorrhea combined with biochemical evidence of ovarian insufficiency. And it's important that the diagnosis should be considered in any any girl who presents with a change in her menstrual cycle, regardless of whether she has symptoms of estrogen deficiency or not. And I'm sure we've all seen, and I certainly have, patients, infertility patients who've been misdiagnosed as PCOS and even given Clomid when they actually have POI. So this won't happen, obviously, if you measure hormone levels. So FSH, to make a diagnosis, FSH and estradiol levels should ideally be measured if the girl still has some periods in the early follicular phase of the cycle. And that's because you want to measure the hormone, the FSH, when the estradiol is still low, because if you have a high FSH, a high estradiol, that can then artificially suppress the FSH level, and you may get invalid results, or falsely you might think they're normal. So an FSH level of greater than 25 measured on one occasion is regarded as diagnostic. Previous guidelines suggested you should have 2 levels, but that never really made sense, because we know that FSH levels fluctuate. A girl with POI can have no periods for several months, and then she can have 3 consecutive periods. So if you measured them on the hormone levels, however, and they're normal, well then, and you're suspicious of the diagnosis, though, it is important. So if you get an abnormal level, you don't need to repeat. If you get normal results, then you should repeat in another cycle or 6 weeks later. And with regard to AMH, this should not be used as a primary diagnostic test, because although it usually correlates, and you will usually see a very low AMH in a girl with POI, which tallies with their high FSH and usually amenorrhea or oligomenorrhea. In some girls with autoimmune POI, you can see a normal AMH, but their FSH is high and they have amenorrhea. And also, we've all seen patients, going through for fertility investigations with very low AMHs, but they continue to maintain regular menstrual cycles for many years afterwards. So what are the causes? Well, the causes of POI can be divided into iatrogenic and non-iatrogenic causes. The main cause of iatrogenic POI remains bilateral ovarectomy, so a surgical menopause essentially. And that might be carried out for cancer or endometriosis, and also for girls who are BRCA carriers who have a risk-reducing BSO, though that is usually recommended to be deferred, well, either until they've completed their family or over the age of 40, when that risk of ovarian cancer starts to become significant. And then there are the girls who have a medical cause, so associated with chemotherapy or radiotherapy or both, usually for malignant conditions. And the commonest conditions we would see girls who've had treatment for childhood cancers, but also then the leukemias, lymphomas, particularly the girls who've had leukemias who've had myeloablative chemoradiation prior to a bone marrow transplant, and they will have ovarian failure and obviously infertility. Then it's probably the next most common group will be the girls who have had brachytherapy and pelvic radiotherapy for cervical cancer. And then the non-iatrogenic causes, well, the genetic causes will include Turner syndrome, probably the main one, though that will usually be diagnosed prenatally or neonatally, or even in early childhood when the little girl presents with short stature and investigation, that karyotype is done. Then other causes include Fragile X, and less common causes such as galactosemia, triple X syndrome, and there are other genetic causes or other chromosomal abnormalities. Then we know that POI can also be associated with autoimmune conditions, particularly Addison's disease and polyglandular syndrome. But in many girls and women, we won't find an underlying cause. So if you see a girl with POI, you should carry out some investigations to try and to see if there is an obvious cause. So the blood tests you should do genetic tests and then tests for the autoimmune and thyroid function. Genetic tests obviously have to be carried out with consent after discussing the implications. And we tend to carry out, we check a karyotype and also test for fragile X pre-mutations. And in some laboratories, next generation sampling is also available, but not nationwide. And that can show up some less common genetic causes. Autoimmune wise, then, we would usually have checked thyroid function and test for anti-thyroid and anti-adrenal antibodies. Now, the new guidelines say you don't need to check for anti-thyroid antibodies because they're so common in the population. And I guess that's correct. But I check for them anyway, because I think if you find anti-thyroid antibodies, well, you're going to be a little bit more vigilant, or ask the GP to be keeping an eye on the thyroid function. And also, girls often like you to find something. So anti-adrenal antibodies, so it's really important that these aren't missed, because because these can obviously, if they have anti-adrenal antibodies, are more likely to develop Addison's syndrome, which can be life-threatening if not recognised and treated. And if you find these, then you refer them on to the endocrinologist for follow-up. I think it's really important that you consider that the most important aspect of the diagnosis is the psychological impact that it will have both on the girl and on her family. So, in young girls, it's very often the mum that is most distressed, and then a partner, if the girl is in a relationship or if she's married, and the diagnosis, or not married, obviously, of course, and the diagnosis is only picked up when the couple start trying for a baby and she's come off her pill, and she finds that her periods haven't come back. So, as I said, in the young girls, they're often the teenagers really aren't sometimes sure what the implications are, and it tends to be the mothers that are most distressed. And I tend to find that. I had one mother who actually burst into tears in the clinic beside the daughter and said, "Oh, I'm never going to have grandchildren." Well, not terribly sensitive with her daughter sitting there, but obviously she understood, I suppose, the distress that infertility might cause her daughter, but obviously she also wanted grandchildren. And young girls, they don't like being different from their friends, obviously. So, that can be a bit of a problem. And they, also may feel embarrassed about taking HRT. And then I think it must be very difficult to navigate relationships, new relationships. At what point does the girl tell her partner that she has this condition? If she tells the boy too early on, he'll possibly, run a mile thinking she's taking this, getting very serious very soon, talking about babies. But if they withhold it and the relationship becomes serious, well, then at what point do they tell? Because their partner may feel that they, have been deceived if they wait till later on. So quite tricky, I would say. And then so I think you can understand why it's really important that we should have clinical psychology help and input for these patients, and referral to mental health services if necessary, and then direct them to the support groups. So for genetic causes, then it's not that common to get a late diagnosis of Turner syndrome. We certainly see it more likely to be a mosaic karyotype. But if you do find it, obviously there are important health implications. So they will need screened for the comorbidities associated with Turner syndrome with appropriate follow-up. And then for some of the other genetic abnormalities, they may also affect other relatives, other members of the family. And this is particularly important when you find that girl to have a Fragile X pre-mutation. And so the other relatives will also require referral for genetic counselling and testing. And this can be very important. And even for girls who maybe you don't find a genetic cause, there is a familial link often. So their younger sisters perhaps may need to take this into consideration so that they don't unnecessarily delay starting their own family. And there may have also be the opportunity, if their sister still has good egg reserve, to consider fertility preservation. And then Fragile X premu carriers, well, it's really important then that this is picked up and their family members are screened because of the risk of abnormalities associated with particularly male babies. Obviously, it's too late for a girl who has been diagnosed. So if a Fragile X premutation is only picked up when she's found to be have POI, well then obviously IVF with PGD is not an option at that stage. And it can therefore pose dilemmas because some of these girls can conceive naturally. And this is just a recent case that I will just present. Rebecca was age 31 and in a stable relationship, not thinking about starting a family just at that stage, but she had stopped her pill and found her periods. She didn't have any periods. So she went to see her GP, who referred her to gynecology. And you can see therefore, well, actually just look at her family history there. First, her mother had a menopause at 37 and she didn't have any siblings. So a family history of early menopause. You will see her first set of hormone levels measured in January of last year were diagnostic, in keeping with ovarian failure, essentially, with an FSH of 93 and an undetectable estradiol. They were repeated 6 weeks later, probably in keeping with the old guidance, and you will see that her FSH was still over 25, but it had come down, but her estradiol level had risen into well within the normal range. Then a month later, they were checked again. I don't really know why, but they were, if you saw those results just as a one-off, you would say they were absolutely normal. And not unsurprisingly, then she had a period 4 days later. So I think I saw her at the end of March. So we discussed the diagnosis, the fact that she had one elevated FSH with her absent periods, and despite the more recent normal hormone levels, she did have POI. And we discussed fertility implications, HRT, etc. And I said I would refer her into my NHS clinic because she'd come to see me for a private consultation. And I said, refer into the NHS and we do the necessary tests. So the genetic tests then were carried out and her karyotype was normal, but she was found to be a carrier of Fragile X. So when I saw her back in October to give her these results, she reported that she was having periods every 3 to 6 weeks. She didn't have any symptoms, so she didn't feel she needed HRT at that point. And I then said I would refer her on to genetic counselling to discuss the implications of the result. So when she had her genetic counselling appointment, she was already 13 weeks pregnant. And she had done some Googling and was obviously anxious about the implications. So because of this, she was advised, obviously it's an X-linked inheritance, so she had a 50% chance of transferring the premutation, and a high risk then if the premutation wasn't inherited, that it could expand further into the full expansion range with a higher chance of abnormalities. So basically, if she had a baby, was carrying a boy who did inherit the premutation, he was likely to have at least moderate learning disability with an increased chance of autism and ADHD, more common in these boys. Trickier then if the baby turned out to be a girl. So girls, even with the full mutation, 50% may have no learning issues, 50% can have some issues, but that can range from mild to as severe as males with no way of detecting that based on the genetic result. So obviously this girl, Rebecca, was really very upset, didn't know what to do, severely conflicted. This was a much wanted pregnancy, possibly her only chance of a baby or not from her own eggs. So really quite upset, didn't know what to do. She decided then in the end, they didn't know, the couple, her and her partner, whether if it turned out the baby, especially if it was a boy, was affected, would they consider termination? She didn't know, but she decided she couldn't bear not knowing. about if the child was affected or not. So they did have an amniocentesis, and thank goodness all was good. She was pregnant with a baby boy, but the baby had not inherited the pre-mutation, so all was well. But just food for thought about how we should counsel these girls even before we have the result back. It may be a fragile X, which actually in my practice I've seen very, very few have come back positive, but obviously big implications if you find it. So, maybe advice to wait before they get the result, maybe not to try for pregnancy. Now, moving on to the health consequences of premature ovarian insufficiency. Well, we know that estrogen deficiency will have an effect on cardiovascular and bone health, sexual function, fertility, obviously, brain and cognition, and life expectancy. So the recommendations from the updated guidelines are that women with POI should be informed that without HRT, it is associated with reduced life expectancy, largely due to cardiovascular disease. HRT is therefore strongly recommended for women with POI until the usual age of the menopause, and that's for primary disease prevention, whether they experience symptoms of estrogen deficiency or not. And remember, many of the young girls, the teenagers particularly, at the time of diagnosis do not have symptoms. Then it is important that we consider that POI is an independent risk factor for cardiovascular disease, and so cardiovascular risk should be assessed at the time of diagnosis, and that will include blood pressure, BMI, lipid profile, diabetes screening, smoking status. And if the woman has a late diagnosis of Turner syndrome as the cause, then they will also need additional screening. They should be referred to the Inherited Heart Diseases Clinic for further assessment for congenital heart disease. And that should include cardiac MRI, which is particularly important prior to considering fertility treatment or pregnancy. In terms of bone health, well, we know that estrogen deficiency is associated with reduced bone mineral density and therefore increased risk of osteoporosis and fractures in later life. Again, particularly important in the younger girls because under the age of 25, they will not have reached their peak bone mass, so their bone density, they may never have achieved normal bone density. HRT is recommended to maintain bone density and prevent osteoporosis and fractures, but the dose of estrogen for these younger women used for prevention of osteoporosis should be higher than the standard doses used for menopausal symptoms. So in women taking HRT for relief of menopausal symptoms, the recommendation is the lowest dose that will control their symptoms. For younger women using it for bone protection, cardiovascular protection, you want to give them higher levels, more physiological levels. So a recommended dose of oral estrogen would be 2 milligrams and a 75 or 100 microgram patch. Many women prefer to take the pill, younger girls, and that is perfectly acceptable. But obviously, if they're taking, and it will provide bone protection, but it should be taken ideally in a continuous regimen for the 21-day pill, because if they're only taking it for 21 days out of 28 each month, well, then they're only getting estrogen for 3 weeks out of every 4, so their overall exposure will be less. I tend to like Clara if they want a pill, because Clara, for anybody who doesn't know, is one of the 2 combined pills which contains natural estradiol like HRT, and it's a everyday pill with 2 placebo pills in each 28-day cycle. So they're getting estrogen for 26 out of 28 days. Then you should also obviously provide the usual advice in terms of diet and lifestyle, making sure that the girl is aware she should have adequate dietary intake of calcium, normalize vitamin D, maintain a normal healthy body weight, engage in weight-bearing exercise, and avoid smoking and other risk factors for osteoporosis. The other treatments for osteoporosis, including the bisphosphonates, are obviously outside the remit of the gynecologist or fertility specialist and should be left to the osteoporosis specialist in collaboration with the GP. To monitor bone health within a baseline DEXA scan is recommended at the time of diagnosis. The new guidelines say there is little value or no proven value on repeating DEXA scans if the baseline DEXA scan is normal and the girl continues with systemic estrogen replacement thereafter. I would argue against that a little bit because, and I would tend to suggest repeating them every 5 years, because a lot of the young girls' compliance, they may tell you their compliance is good because they know you want that answer, but often if you find, for example, you do any serum estradiol level, you find it's low and you say, did you really take your tablets? Did you miss any? Oh, well, I forgot to get my new prescription. So you imagine a young girl who's off at university, she runs out of her HRT, she's no symptoms, she's not going to go phoning the GP who she can't get through to anyway to ask for another prescription. So I think, you may be alerted to the fact that compliance is poor if you find that the bone density is reduced. So that's for me as a reason. And the Turner's girls, well, they will absolutely remind you that they should have a bone scan every 5 years. If you find obviously a deterioration in bone density, so you have osteopenia, osteoporosis, then you should repeat the measurements within 3 years. And again, if the bone density is continuing to decrease and you've excluded poor compliance with estrogen, poor absorption of estrogen, perhaps orally or transdermally, by measuring a serum estradiol level, or maybe excluded something like celiac disease, well, then if you can't find a reason, you should refer them on to the osteoporosis clinic for further advice. A surgical menopause, so bilateral supingo-ovarectomy, has been found to be associated with an increased risk of cognitive decline and dementia, as well as Parkinson's disease and Parkinsonism in women who have not had a replacement of their estrogen. So this should therefore be discussed with women, advised of this if they're considering a bilateral ovarectomy, but obviously under the age of 45, actually, so early menopause as well. But obviously for some women, they may not have a choice. So they've got cancer, they have to have the ovarectomy. But if they're considering maybe for some non-malignant reason, then it's something to consider. Even in women who...
She's good. How are you?
Fine. Even women who've had a non-surgical menopause and natural early menopause up until the age of 47, there may be an increased risk of dementia. So HRT is therefore recommended in women with POI to reduce the possible risk of cognitive decline and dementia. With regard to sexual function, well, we know POI can have a significant impact on sexual well-being and function. It may be a primary effect, or it could be a secondary to the emotional burden of the diagnosis and associated infertility. The problems are usually genital urinary symptoms and low libido. So usually the symptoms should respond to adequate systemic estrogen replacement. But often the younger girls in particular require, even though they've good systemic estrogen replacement, they often require and will benefit from additional local estrogen for their genital urinary symptoms. With regard to testosterone, we know that there's no correlation between testosterone levels and sexual function, but nevertheless, some particularly younger women may benefit from testosterone. And traditionally, before testosterone became extremely popular and everybody wanted it, we would have given it if they had residual symptoms, we would have prescribed it for particularly the younger girls who had a surgical menopause. We found they were the ones that tended to miss it and may have benefited from it. And that was when we used to be able to offer them testosterone implants. But it is important to advise women who are taking testosterone that there is no data for long-term efficacy and safety. And also really important, if the girl still has a chance of conceiving naturally, so she hasn't had a surgical menopause, that it's important to avoid supraphysiological levels. And even with women using the recommended dose for females, then I have often seen alarmingly high levels. So it is important to be aware of that, particularly because there is potentially a risk of virilization of a female fetus, or sorry, a male fetus in women who, if they have very high levels. So for fertility then, most women who are going to have treatment that will render them, give them ovarian failure or infertility should be offered fertility preservation, time allowing. Women with idiopathic POI should be informed that there is a small chance that they might conceive naturally. And that is thought to be in and around 2.5 to 5%. Obviously, it varies. Younger women who still have some periods, that may be higher, and they may have a window of opportunity, a bit like the girl I presented earlier. So if the girl, however, doesn't want this little chance of a miracle pregnancy, she should be advised to use contraception if it's not an appropriate time in her life for that to happen. If a natural pregnancy doesn't occur or it can't occur, then there's obviously the only proven effective treatment is IVF combined with egg donation. But if they should consider, if they're thinking about their sister being a donor, that there may be this shared genetic risk of POI, which would obviously be associated with a lower chance of success. But obviously we're going to measure all donors' AMHs before recruiting them. If they are considering a pregnancy, we need to consider what the reason for their POI is, and could this be associated with particular pregnancy risks. So this would be particularly with Turner's syndrome, pelvic radiotherapy, or if the girl has had a chemotherapy with cardiac toxicity. Reassuringly, if a girl with idiopathic POI and no other problems conceives naturally, then her pregnancy should just be like any other pregnancy with no significant excess risk, and hopefully she can enjoy it. If there's pelvic radiotherapy, particularly if the pelvic radiotherapy has been administered in pre-pubertally, well, then there's damage to the endometrium, myometrium, and it can be associated with low uterine volume, with an increased risk of miscarriage, preterm birth, and therefore low birth weight babies particularly. If the girl has had cardiotoxic chemotherapy, usually they're followed up by cardiology, but they should be pre-assessed prior to embarking on a pregnancy because of the risk of cardiomyopathy and heart failure. And they can also get cardiac damage from scatter radiotherapy, from mediastinal radiotherapy. So preconceptional assessment is very important. Egg donation pregnancies should be considered as high risk, and it's important again that although the couple may not wish to divulge this information to many people, they should inform their obstetric team so they can be aware and anticipate the possible complications. The particular risks are for pregnancy-induced hypertension and postpartum hemorrhage. So these girls should be, their pregnancy and their delivery should take place in an appropriately staffed obstetric unit. Turner syndrome pregnancies are regarded as very high risk, and the literature quotes a maternal mortality rate of approximately 3.5%, so quite alarming for any girl with Turner syndrome who's considering fertility treatment. And the risk seems to be associated to abnormalities of the aortic valve and aortic root dissection. I suspect with careful preconceptual monitoring, and certainly all our girls would be under regular review. All our girls with Turner syndrome would be under review with our very helpful Inherited Heart Diseases Clinic, and they will have 5 yearly cardiac MRIs. Many of them will have bicuspid aortic valves. But less so sometimes they detect, they measure the aortic roots, and they may advise them not to embark on pregnancy. But if they do become pregnant and their cardiologist is happy that they embark on a pregnancy, well, then they should be obviously looked after in a joint obstetric and cardiac clinic. And it goes without saying that she should only ever have one embryo transferred to reduce that risk of all the other complications that are increased with a multiple pregnancy. And I can remember It was a long time ago, but we had one patient who with Turner syndrome. She didn't have her IVF in Belfast, but she delivered twins in our labour ward, and she died. She collapsed and died shortly after delivering the twins. And the PM did not show any aortic root dissection, aortic problem. It just reported that she had a small heart. So I don't actually know what happened there, but obviously just remember these pregnancies are high risk. So let's just talk briefly about HRT to finish up. So HRT is recommended, we know, in women with POI until the usual age of the menopause for primary disease prevention. And after that, when they reach the age of 50, then they can consider themselves like anyone else at the normal age of the menopause, and their decision about HRT should be based on whether they require it for symptoms and a risk-benefit analysis at that time in their lives. Important again that they appreciate that HRT is not contraceptive. So as I said before, if they don't want that little chance of a miracle baby happening, they need to make sure that they take a contraceptive preparation. Again, ideally, I would probably suggest Clara, because they'll get good bone protection and it contains natural estradiol. If pregnancy is, however, desired, it is important that you choose an appropriate form of HRT. So if they don't want to prevent a pregnancy, they should have a combined sequential preparation, one that contains either progesterone or dydrogesterone as the progestogen, because we know that these are used as luteal phase supplements in IVF treatments, and they are not contraceptive. The only single oral preparation that contains both estradiol and dydrogesterone is Femiston 210. There is no combined sequential HRT preparation which contains estradiol with progesterone. So Femiston 210 tablets are my go-to really for most of my young girls with POI who don't want to prevent pregnancy. It's a physiological form of hormone replacement. It is one single tablet. It is easy. And I also can reassure them that I have had many pregnancies over the years in girls with POI taking Femiston 210. So it's not contraceptive. If the girl doesn't want to bleed, so sometimes they say, I don't want to have a period, can you give me something that I won't have a period on? Yes, you can. But remember that these continuous combined HRTs have estradiol combined with daily progestogen at a higher dose than that in a progestogen-only pill, so they will have a contraceptive effect. They're not licensed as contraceptives, obviously, but they will have a contraceptive effect. And then just to say that there is no good evidence to favour transdermal versus oral estrogen. Yes, transdermal is estrogen is potentially more physiological, but unless a girl has a contraindication to the use of oral estrogen, usually it is handier, it's less obvious, and their compliance is likely to be better. So if they want transdermal estrogen, there is no, and there will be some women who have a contraindication to oral estrogen, which is predominantly a high VTE risk. But if for most young girls, to use a patch, it's obvious. There isn't a combined patch that has an adequate dose of estrogen for younger girls, so they will have to use separate transdermal estrogen patch or gel, and then remember to take tablets either daily for a continuous regimen or 12 days a month for a sequential regimen. So it is really, a bit more hassly and more likely to lead to poor compliance. So just to finish up, the risks of HRT, and if you're counselling the patient, many are worried about breast cancer. Older relatives say you shouldn't be taking that. There's a risk of breast cancer, but we know there's no evidence of any increased risk of breast cancer associated with HRT use under the age of 50. We know that an early menopause or POI without estrogen replacement is associated with a reduction in risk of breast cancer. But if you give back estrogen, that's only bringing it up to what the risk would be if in their similar to their peer group who don't have POI. For BRCA carriers who haven't had breast cancer but have had a risk-reducing BSO, HRT is recommended, but just up until the age of 50. And it doesn't seem to negate that reduction in breast cancer risk associated with having their ovaries removed. HRT is obviously, though, still contraindicated and not recommended in women with a history of breast cancer. And in women with endometriosis who've had a pelvic clearance, even if they'd have had a hysterectomy, both estrogen and progesterone are recommended, and that's to prevent the proliferation of any residual endometriosis deposits in the pelvis, which could cause recurrence of pain and also recurrence of pain and potential malignant transformation. For other gynae cancers, HRT isn't associated with any increased risk of recurrence in squamous cell carcinoma or early stage low-grade endometrial adenocarcinoma. It's suggested that due to lack of evidence, there's an individualized approach for adenocarcinoma, but in real life, most girls who've adenocarcinoma, it occurs when they're young, so most of them are taking HRT. For non-epithelial ovarian cancers, you should consider the hormone receptor status, and obviously for the gynae cancers that are hormone dependent, sarcoma, endometrioid carcinoma, ovarian clear cell, granulosa, sex cord stromal tumours, then HRT should generally be avoided. That can be tricky, very difficult if this is in a young girl. I have a young teacher at the minute, primary school teacher. She is also taking been prescribed adjuvant letrozole for additional benefit to reduce potential recurrence, and she's really struggling. So we'll just leave you with the final slide there, just showing you support groups, the DAISY network for POI, the very helpful Turner Syndrome Support Society group, and then just the new guidance, their patient resources. So thank you.
That's great. Thank you very much, Joanne, for a fabulous lecture and a good overview of POI. Could I just ask a quick question? You know, with regard to the dose that you said about, that we need to increase the dose, compared to the conventional HRT, and the BMS says, the 2 milligram is equal to 50 microgram patch. But in the guidelines, and as you mentioned as well, it is 2 milligram oral or 100 microgram patch. Any comments on it?
Yes, I actually don't think from measurement of levels that the 2 milligram is equivalent to a 50 microgram patch. I think 2 milligrams is more equivalent to a 75 or 100, and I'm aware of that in the BMS, and I've always got a wee bit of an issue about that, but I haven't raised it. But yes, generally 50 microgram patch we have found is more equivalent to a 1 milligram of oral estradiol. But obviously it also depends on metabolism. And certainly we see, girls on a 1 milligram dose of estradiol who have a dose that is more, a dose above 250, which we picomoles per litre, a level above 250 picomoles per litre, which is regarded as probably what we'd aim for bone protection. And then in that case we wouldn't increase the dose. So I think it does vary, but a 50 microgram patch generally isn't really regarded as high, and certainly the POI guidelines do recommend the higher dose.
Yeah, thank you. Just one more question. Uzma Zafar, do you want to ask quickly?
For a very informative talk. Just want to check, women who have had a BRCA1 mutation and ovarian cancer, which is treated surgically as well as with chemo, can they go on HRT?
Well, if they've had ovarian cancer, so their ovaries are removed. Yeah. Well, they can, but what about their breast cancer risk? Have they had, a lot of these women will maybe also have had a bilateral mastectomy as well. So if they've had a risk-reducing mastectomy and their ovaries removed, yes, they can go on to HRT, but if they haven't had their mastectomy, you also then have to be mindful. But under 50, yes, they can have it. But over 50, it's recommended then that even if they've had the bilateral mastectomy, that they don't necessarily take HRT. Though again, it's a you also have to look at an individualized risk benefit analysis and perhaps liaise with their oncologists. But if they've had their ovaries removed from the ovarian cancer point of view, yes, they can have estrogen.
Thank you.
Thank you very much. We'll move on to the next lecture.
Perfect.
Emily?
Thank you very much, Joanne. That was absolutely fantastic. So our next speaker is joining us in between theatre cases. So our next speaker is Neelam Potter. So thank you so much for joining us, Neelam. So she is a consultant gynecologist and subspecialist in reproductive medicine and surgery in University Hospitals of Leicester NHS Trust, and she's been appointed since 2012. In addition to being reproductive medicine specialist and clinical lead for the fertility centre there, she also provides surgical treatment for complex endometriosis. She was one of the initial consultants who worked on obtaining the BSGE Endometriosis Centre accreditation in UHL. And Ms. Potter does a lot of research. She's very active with various presentations and peer review publications. Her research interests include male infertility, endometriosis, and early pregnancy. And she has been the co-chair for the RCOG Guidelines Committee and is currently a member of the NICE Women's Health Suites Committee. So we welcome her and her talk today on male factor infertility. Neelam, are you able to share your slides?
Do you want to do it at your end?
Yes, of course, I'll do it, no problem. Right, so can you see my slides?
Not yet.
Let's see if I can.
We
Jay,
can.
you can? Jay, can you see my slides? Yes.
I can see Emily. Yeah. Yes, Neelam.
Okay.
Can you not?
Okay.
Neelam?
No, so sorry. I'm so sorry. Pre-lunch, we are having.
No, you're okay.
Problem. 2 seconds, please. I think I know what the trouble might be. Let me just troubleshoot. 2 seconds.
Do you want to try and share yourself?
Yeah, give me 1 second, please. Yeah.
Sure, I'll stop sharing, but I'm ready if you need me to. So yes, if you hit share and then window, if you've got your slides open.